Welcome to the deep dive. Today we're zeroing in on a condition that sounds a bit contradictory. Uncomplicated type B aortic dissection, or UTBAD.
Right. That word uncomplicated can be misleading.
Exactly. You hear uncomplicated and think maybe it's minor, but, well, there's a real catch.
There is. So just quickly, an aortic dissection is basically a tear inside the wall of the aorta, the big artery coming off the heart.
Okay.
And uncomplicated in this specific context just means there's no immediate threat to blood flow going to your vital organs, at first anyway.
Right. So not an emergency room crisis right that second.
Right.
But here's the twist we mentioned. Even if the initial treatment, usually medication, looks like it's working well, there's still a pretty significant chance that things can, well, fail down the road, often needing some serious intervention, maybe in a surgery, maybe one of those less invasive endovascular repairs.
That's the core issue. So the big question we're tackling is, when is just managing with medication not going to be enough for UTBAD in the long term?
Yeah, how do we know?
Precisely. And to help us get a handle on this, we're digging into a really useful study. It's a retrospective look, meaning they look back at patient data.
Okay.
Specifically, 314 patients with UTBAD. They were all treated initially with what's called optimal medical therapy, or OMT. Think really careful blood pressure control mostly.
And where was this study done?
This was at Emory University School of Medicine, looking at patients between 2000 and 2016. And the findings were published back in 2019 in the Annals of Thoracic Surgery.
Got it. So our mission for this deep dive then is to really understand what factors popped out in this study, what tells us that this initial medical approach for UTBAD might, eventually fail, leading to maybe needing surgery or worse.
Exactly. What are the warning signs?
Let's start with the basics. Who are these patients in the study, generally speaking?
Well, the average age was around 58, and it skewed male, about two-thirds, 67% were men.
Okay.
And the really crucial part, like we said, is everyone started on that optimal medical therapy. The focus was tight blood pressure control right from the beginning.
Okay, so they all got the standard best medical care initially. But what happened over time? Did that therapy hold up? You mentioned this sort of paradox.
Yeah, the results are quite striking, actually, over a median follow-up time of about 5.6 years. Nearly half the patients, 44.9% to be precise.
Wow.
That's 141 people out of the 314.
Yeah.
They ended up needing some kind of intervention later on, either traditional open surgery or an endovascular repair.
So almost 1 in 2.
Pretty much. The researchers estimated the overall likelihood of OMT failure was around 46%. That really underscores why finding predictors is so important. We need to know who's at higher risk.
Absolutely. 46% failure is significant. So what were the key factors when they crunched the numbers, doing that multivariate analysis you mentioned?
Right, the analysis that tries to isolate the truly independent factors.
Yes, what really stood out as predicting failure?
Okay, so a few things emerged as independent predictors. One was having diabetes. Another was pre-existing kidney problems, renal failure.
Makes sense. Those often indicate wider vascular issues.
Exactly. And also, the type of dissection mattered. Specifically, what's called the DeBakey 3B dissection.
DeBakey 3B, can you quickly clarify that?
Sure. It just describes where the dissection starts and extends. Type 3B means it starts after the artery to the left arm and is primarily in the descending part of the aorta, down in the chest.
Got it. Location matters. So diabetes, kidney failure, DeBakey 3B, were those the main ones? I feel like there was something else really emphasized.
You're right. There was one factor that stood out above the rest. The single most significant independent predictor was the diameter of the descending thoracic aorta, measured right when the patient was first diagnosed.
The size of the aorta itself.
Yes. Specifically, if that diameter was 4.5 centimeters or larger, that was the critical threshold they found.
4.5 centimeters. That sounds like a very concrete, measurable red flag. How strong was that link statistically?
Very strong. The hazard ratio, which kind of indicates the increased risk, was 1.39. And the confidence interval was tight, 1.24 to 1.56. Crucially, the p-value was less than 0.001.
So highly statistically significant, meaning it's very unlikely that finding was just chance.
Exactly. A bigger aorta at the start strongly predicts that medical therapy alone is, well, more likely to fail later on. But, here's where it gets really interesting. Some things you might expect to matter didn't.
Okay, yeah, I remember reading that. Things that seem intuitive but didn't pan out in the analysis.
Precisely.
Yeah.
Like the status of the false lumen, that channel created by the tear.
Right. Is blood flowing through it? Is it clotted off?
Exactly. Whether that false lumen was patent, meaning open or partially thrombosed or fully thrombosed. Surprisingly, that did not predict OMT failure in the final multivariate analysis.
Really?
Yeah. It showed maybe a tiny hint of significance in the simpler initial look, but when they accounted for all the other factors, especially the diameter, its predictive value basically disappeared.
That is fascinating. Because you'd think, almost instinctively, that an open false lumen with ongoing flow would be a recipe for more problems later.
That's the common thinking, yeah. And similarly, another thing that didn't predict failure was which visceral arteries, the arteries supplying the gut and kidneys, were coming off that false lumen versus the true lumen.
So even if major organ arteries originated from that new channel, it didn't necessarily mean medical therapy was more likely to fail.
According to this study's multivariate analysis, no. It refines our understanding quite a bit, moving beyond just the simple anatomy you see on the scan.
Okay, so the study itself found these predictors, mainly the aortic diameter. What did the authors, the researchers themselves, say about these findings? How do they interpret it in the bigger picture?
Well, they definitely reinforced the significance of that initial aortic diameter, that 4.5 centimeter number. And they also noted that some other studies have even suggested maybe a slightly lower cutoff, like 4.0 centimeters, could be a point of concern.
So diameter is key. What else?
They provided some important historical context, too. They talked about how, years ago, open surgery for aortic dissection was really risky, high mortality rates, which naturally made doctors lean heavily towards medical management whenever possible. It seemed like the safer initial route if the patient was stable.
That makes total sense. Avoid a dangerous surgery if you can manage it medically, at least initially.
Exactly. But then, things started to change with the advent of endovascular repair. Specifically, TEVAR, thoracic endovascular aortic repair, using stent grafts.
The less invasive option.
Right. These devices started becoming available around 2005, and then got FDA approval specifically for dissection in 2012. This gave doctors a powerful, less invasive tool compared to open surgery.
And that, I suppose, created the current dilemma, didn't it? Now that we have TEVAR, who should get it early and who should stick with just medication?
That's the million-dollar question. The authors touched on this complex decision-making. They mentioned a couple of important trials, ADSORP and INSTEAD.
What did those show?
Well, ADSORP looked at early TEVAR in uncomplicated cases. It didn't actually show a clear survival benefit for intervening early, but it did suggest that early TEVAR led to better aortic remodeling.
Remodeling, meaning the aorta healing or reshaping itself better.
Yeah, basically encouraging the false lumen to clot off and the aorta to return to a more normal state. INSTEAD, which had a slightly different focus, also showed benefits in terms of remodeling with endografting.
So the thinking is maybe hitting it early with TEVAR helps the aorta heal better while it's still maybe more pliable, more capable of healing.
That's the general idea, yes. It aligns with the broader medical concept that earlier intervention often leads to better long-term structural outcomes. Catch it before things get worse.
But there's a flip side, right?
Definitely. The authors were careful to point out the risk of overtreatment. You don't want to subject patients to an invasive procedure, even TEVAR. If their dissection might have actually done perfectly fine and stabilized with just medication alone, it's a real balancing act.
Finding that sweet spot. And it's interesting their study didn't back up that idea about the false lumen outflow vessels. The idea that more vessels coming off it might lower the pressure.
Right. That hypothesis that more outlets might be protective wasn't supported by their data. Seems counterintuitive, but that's what they found.
Did they talk about how dissections are classified over time?
Briefly, yes. They mentioned the evolving classifications, acute, subacute, chronic, based on how much time has passed since symptoms began. And they highlighted that the ultimate goal is really to identify which specific aortic flaps, the torn tissue itself, are most likely to respond well and heal after placing an endograft. We're not quite there yet.
So for now, what's the most reliable guidepost we have based on their work?
It comes back to that baseline measurement. Right now, initial aortic diameter seems to be the best, most reliable predictor we have for predicting late failure of medical management.
And is this changing how doctors approach these patients?
It seems so. The authors mentioned that based on findings like these, their own practice is shifting. They're more inclined now to consider earlier TEVAR, maybe even during the first hospital admission, for patients who present with those larger aortic diameters, over 4.5 centimeters.
But intervention isn't the end of the story, is it? What about follow-up?
Oh, absolutely critical. They stress that whether a patient gets medical therapy or TVAR, ongoing surveillance with imaging is essential. You have to monitor the aorta to ensure the treatment worked, that it's stable, and that there's no further expansion, dissection, or problems with blood flow.
So it's not a treat and forget situation.
Not at all.
Right.
And they concluded by saying, look, our current ways of predicting risk, these clinical markers like diameter, they're still relatively crude. We really need a deeper biological understanding of which aortas, which specific tissue characteristics will benefit most from early endografting versus which will do fine with medication.
Okay, let's try to crystallize the main points for you, our listener. The absolute key takeaway from this deep dive into the Emory study. If you're dealing with an uncomplicated type B aortic dissection, the size of that descending aorta when it's first diagnosed is a really big deal.
Huge deal.
If it measures 4.5 centimeters or more, this study strongly suggests that medical management alone has a significantly higher chance of failing down the line. So that initial size is a major flag.
And don't forget, diabetes and kidney failure, those were also independent risk factors identified. Important pieces of the puzzle.
Right, but the headline really is, a significantly enlarged aorta at diagnosis means medical therapy alone might not be the durable solution everyone hopes for.
And interestingly, perhaps counterintuitively for many, things like whether that false channel was clotted or open or which branches came off it, those didn't turn out to be reliable predictors of failure in the study's most rigorous analysis.
Yeah, that's a crucial nuance. The simple picture isn't always the full picture.
Exactly.
So it's clear that while optimal medical therapy is the standard starting point for UTBAD, our understanding is evolving fast. This study gives us vital clues about who might need more than just medication. There's this ongoing debate, this balancing act between watchful waiting with meds and earlier intervention with TVAR.
And this research strongly points towards using that initial aortic diameter as a key factor in tilting that balance.
It really helps answer that question we started with. When isn't medical management enough? A large initial diameter is a big part of the answer.
It certainly seems to be.
Okay, so for our final provocative thought for you to consider, if baseline aortic diameter is currently our best predictor, but still considered crude, what's next? What kind of future research, maybe advanced imaging techniques, or perhaps even biological markers, could give us a much more precise way to predict how an individual's aorta will behave long-term after dissection? Can we get beyond just size to understand the actual health and healing potential of the aortic wall itself?
That's the frontier, really, moving towards more personalized risk assessment.
Something to think about. Thanks for taking this deep dive with us today.